for the FMG exam, but still, because you're talking about it, the mechanical thrombectomy, when we want to do it, the best outcome comes when this 3 points you have to remember for the best outcome. The best outcome comes when it is done within 6 hours. Though generally we consider it as a first line management for patients presenting after 4.5 or 6 hours, but if it is done within 6 hours, it actually gives the best result. So like those patients who presented within 6 hours, thrombolysis failed, and then we go for the mechanical thrombectomy, that is where we get the best outcome. Second is when the National Institute of Health stroke severity score is more than or equal to 6, and there is a CT grading called aspects CT score, that also more than or equal to 6. So it's easy to remember. It's all about 6 here, right? Done within 6 hours, and the scores more than or equal to 6 is where we get the best outcome for mechanical thrombectomy. Okay, that's like the most difficult question that they may ask from the stroke, and that's also covered. Now let us talk about Alzheimer's disease. Alzheimer's disease, like we know, is a neurodegenerative disorder. It is the most common neurodegenerative disorder, and is called as senile dementia because it usually affects people aged more than 60-65 years. Less than that, it can occur. If it occurs early, we call it as early onset Alzheimer's disease, EOAD. Okay, now it is due to accumulation of two substances in the neurons. The first one is amyloid beta, the second one is tau proteins, hyperphosphorylated tau proteins. And these accumulations, as you know, they are visible in the microscope as what we call as neurofibrillary tangles and neuritic plaques. So the inclusions that we get here are called as neurofibrillary tangles and neuritic plaques, and large accumulations can be called as Hirano bodies. They can be called as Hirano bodies. Now, clinically, the disease progresses. The earliest site to get affected by neurodegeneration because of the substance accumulation is the temporal lobe, and to be more precise, in the temporal lobe, it is the hippocampus. So the first to get affected or earliest to get affected is going to be hippocampus. In the hippocampus, it is the temporal hippocampus is there in the temporal lobe, and this is concerned with, so this usually leads to short-term memory deficits. That's why the earliest symptom of Alzheimer's disease is short-term memory deficits. From there, this area gets affected first, hippocampus, which is the medial part of the temporal lobe, not visible laterally. It's the medial part of the temporal lobe. From there, the degeneration, this is the first site. The degeneration generally spreads to parietal lobe, the parietal lobe. So from here, it spreads to parietal lobe. Particularly in the parietal lobe, it is affecting the angular gyrus. That is the second affected structure. Parietal lobe, to be more precise, angular gyrus. And this angular gyrus is concerned with what are the functions that angular gyrus does? Your ability to write, read. So you lose your ability to learn. So when you lose your ability to write, we call it as agraphia. When you lose your ability to learn, it is called as alexia. When you lose your ability, like this is required for calculation. So when you lose your ability to calculate, we call it as acalculia. This angular gyrus is also required for left and right differentiation. So you may lose that. So you can have left-right disorientation or confusion, or it's also called as visuospatial disorientation. And it is required for you to identify fingers. So you can develop finger agnosia. This angular gyrus is active only on the dominant parietal lobe. And if the non-dominant parietal lobe gets affected by neurodegeneration, then you can have hemispatial neglect. Patient starts neglecting one side of the body, and they also develop what we call as constructional apraxia. Now, what is apraxia? Apraxia refers to loss of learned skill. We have learned to make tower of different objects as we grow, but once I develop this damage to the non-dominant parietal lobe, I lose my ability to build the simple towers. We will call it as constructional apraxia. Constructional apraxia. So you can get constructional apraxia. These are the symptoms that appear later. The first symptom is going to be short-term memory deficits. Eventually, all these symptoms may appear. And the angular gyrus involvement, whatever symptoms it is leading to, collectively, we call it as Gerstmann syndrome. Gerstmann syndrome, which can occur in a patient with Alzheimer's disease. Eventually, from the parietal lobe, the degeneration spreads to frontal lobe, particularly the prefrontal cortex. And once the frontal lobe gets affected, the involvement of frontal lobe leads to frontal lobe, mainly the prefrontal cortex, which is concerned with personality and behavior. Concerned with personality and behavior. Prefrontal cortex. So once that gets involved, the patient will have personality and behavior changes and behavior changes. So these are the symptoms we can anticipate. So what are the three most commonly affected lobes? The most affected lobe is the temporal lobe, which is there in the hippocampus. So temporal lobe is the most affected lobe in Alzheimer's disease, followed by the parietal lobe. It could be dominant or non-dominant. Dominant affected, angular gyrus gets affected, you will have this Gerstmann syndrome. All A's, agraphia, alexia, acalculia, right left confusion, and finger agnosia. If non-dominant, patients will have hemispatial neglect. They'll start to neglect one side of the body, and they will develop constructional apraxia. And then eventually frontal lobe gets affected, where the personality and behavior of the individual starts changing, right? So these are the symptoms we are expecting. That's about the progression of the disease. Now that we know how the disease is going to progress, let's understand how do we make a diagnosis. So when it comes to diagnosis, the diagnosis is usually clinical by ruling out reversible causes for dementia. In your workbook, you have a list of reversible causes for dementia. So please go through them. I don't want you to forget the most common ones, that is thiamine deficiency causing Wernicke-Korsakoff's encephalopathy, and then niacin deficiency causing pellagra, hypothyroidism. These are common reversible causes for dementia that you should not miss. If you do a MRI scan of the brain in a patient with Alzheimer's, the earliest site where neurodegeneration is happening is hippocampus. So MRI may show hippocampal sclerosis or hippocampal atrophy. Hippocampal atrophy is the earliest MRI finding. This is the earliest MRI finding. As parietal lobe also gets degenerated, then parietal lobe will become atrophied. Eventually frontal lobe will also become atrophied. This earliest MRI finding, that image is there in your workbook. As you can see, this is the temporal lobe. This is the medial side of the temporal lobe, and this medial side is what we are going to call, this part is what we call as hippocampus. This is a normal hippocampus. This is atrophic hippocampus. And as you see, the space is liberated here because the hippocampus is shrunken. Atrophy of the hippocampus is the earliest MRI finding in patients with Alzheimer's disease. Now we know how to diagnose it. Let us look at its management. And when it comes to the management of Alzheimer's disease, the key point you need to know is that the dead neurons are mainly using acetylcholine. So we want to increase the acetylcholine in the neurons so that they can function better. Second, we want to prevent further death of neurons by preventing accumulation of either amyloid beta or tau proteins. So to improve symptoms, we need to increase acetylcholine. And how do I increase acetylcholine? I can achieve increase in the acetylcholine by using acetylcholine esterase inhibitors. And what is the drug of choice for Alzheimer's disease? I want an acetylcholinesterase inhibitor which is long acting and crosses the blood-brain barrier to reach the brain, reach the hippocampus, parietal lobe, frontal lobe, and that is going to be donepezil. And what other acetylcholinesterase inhibitors that can be used? That includes rivastigmine and galantamine. And I also want you to remember that there was one more drug called as tacarine, which is no longer available in the market. This is withdrawn due to risk of hepatotoxicity. This is an MCQ that they may ask you. This is a potential MCQ point. So that is one class of drugs. The other class of drugs that we can use, these are NMDA blockers like memantine, but these are not as effective as acetylcholinesterase inhibitors. That's why they are not routinely used. They are not greatly effective. They are to some extent okay. So that's why most of the patients today, if they are diagnosed with Alzheimer's, they will be receiving donepezil, long acting, high blood-brain barrier penetration. Okay, so that is to improve symptoms. That is one goal I have. I have a second goal, to slow disease progression. How can I slow disease progression? We can slow the disease progression by either inhibiting amyloid beta accumulation or tau. We don't have anything that inhibits tau accumulation. We have drugs that inhibit amyloid beta accumulation. What are those? Lecanemab and aducanumab. These are monoclonal antibodies against amyloid beta. So they inhibit amyloid beta accumulation. Okay, and because these prevent death of neurons, the best use is possible when you start them early. Late, when neurons are dead, they are of no use. They are not reviving neurons. They prevent death of neurons. So these are most effective when started early. When started early. Okay, that's about the Alzheimer's disease. What are important MCQ points? Drugs I want you to remember. You should be able to recognize Alzheimer's disease from a question when they mention that patient has got short-term memory deficits. We forgot to mention Alzheimer's disease when we are talking about it. Among the risk factors, most importantly, genetics. Age is definitely a risk factor. In terms of genetic risk factor, I want you to remember mutation in presenilin 1 and another mutation, that is ApoE4 variant. They are associated with increased risk of developing Alzheimer's disease. Okay. Next, we will talk about one more neurodegenerative disorder, that is Parkinson's disease. Parkinson's disease. So first we will understand what is Parkinsonism. Parkinsonism refers to any patient with bradykinesia plus rigidity. Bradykinesia plus rigidity, we call it as Parkinsonism. And this Parkinsonism we will classify into Parkinson's disease, and then drug-induced Parkinsonism and Parkinson's plus syndromes. Parkinson's plus syndromes. Okay, so drug-induced, what drugs can cause Parkinsonism? Depletion of dopamine is responsible for Parkinson's disease. So anything that blocks dopamine, it could be antiemetics, it could be antipsychotics, anything that blocks dopamine can cause Parkinsonism, drug-induced Parkinsonism. Okay, now what comes under Parkinson plus syndrome? Under Parkinson plus syndrome, we have dementia with Lewy bodies. Dementia with Levy body. In all these Parkinson plus syndromes, they have bradykinesia plus rigidity. In addition to that, they have one more plus feature. That plus feature in dementia with Levy body is the dementia. Then second, we have progressive supranuclear palsy. Supranuclear palsy. So what is the plus feature in this progressive supranuclear palsy or PSP? The plus feature in PSP is they have vertical gaze palsy.